Good day, my name is Cacciari and I'm here today to present morphometrical and functional outcomes following pelvic floor physiotherapy to treat urinary incontinence in older women. We have no interest to declare. Urinary incontinence, as we all know, is a chronic and debilitating condition highly prevalent in older women, creating embarrassment and negative self-perception. Pelvic floor muscle training, or PFMT, is first-line treatment for stress and mixed UI in women with level of evidence 1 and grade of recommendation A. Evidence from our recently published trial, the group trial, showed that older women with stress or mixed UI will attend, adhere, and gain clinically important benefits from a group-based PFMT approach, as they do with the standard of care individual PFMT. Here we present a secondary analysis of this trial focused on the investigation of the morphometrical, functional, and related self-efficacy effects of these two physiotherapy approaches to treat UI in older women. So first, I will present you the group trial, which was a randomized non-inferiority trial comparing individual to group-based physiotherapy immediately post-treatment and at 1 year. The sample size of 362 women was based on its primary outcome, the percentage reduction in UI episodes. Eligible participants were community-dwelling women aged 60 and over with 3 or more episodes of stress or mixed UI per week during the preceding 3 months. Intervention was similar between study arms. First, they all went through an individual evaluation to make sure they knew how to properly contract their pelvic floor muscles. Then, both arms received the same 12-week training program, supervised by a physiotherapist, either individually or as part of a group of 6 to 8 women. Either way, supervised weekly sessions lasted 1 hour. Finally, they were assigned home exercises throughout the study. Outcomes were assessed at baseline, immediately post-treatment, and at 1 year by an outcome assessor blinded to the participants' allocation, and included pelvic floor morphometry using transperineal ultrasound volumes, pelvic floor muscle function using the Montreal dynamometer, and participants' perception of self-efficacy in performing pelvic floor muscle exercises using the Broom pelvic floor muscle self-efficacy scale. Morphometric parameters were assessed at rest, during pelvic floor muscle contraction, and on cough, and included in the sagittal view the vertical position of the bladder neck and of the pelvic floor muscles, and in the axial view, dimension and area of the hiatus. Functional parameters were specific to each task, including mean rest force, maximal tolerated vaginal opening, peak force on maximal contraction, speed of contraction and relaxation on rapid contractions, area under the curve on sustained contraction, and peaks and valleys of force on the triple cough. Here are the participants' demographics. They were on average overweight and with a mean duration of symptoms of 10 years. From the 362 participants enrolled, data was available from 80 to 90% post-treatment and 70 to 80% at 1 year. No imbalances were found between study arms or between completers and non-completers. For pelvic floor morphometry, no difference were found between group-based or individual PFMT. No time effect was found for the rest or contraction tasks, but for the cough, they both resulted in smaller hiatus and lower descent of the pelvic floor muscles, though with small effect sizes. It was interesting to see that these results were maintained at 1 year reassessment. For pelvic floor muscle function, there was an intervention effect favoring the individual arm for the number of rapid contractions at 1 year, but except for that, no further differences were found between arms. Neither presented time effect for the rest task outcomes, but both presented higher maximal forces, faster contraction and relaxation speeds, with higher number of rapid contractions, higher area under the curve of the sustained contraction, and higher peaks and valleys of force on the triple cough. Overall effect sizes were small, and again for all tasks there were no difference between post-treatment and follow-up. For self-efficacy, an intervention effect was observed slightly favoring the group arm. Both interventions resulted in higher scores, with over 90% of the participants reporting high self-efficacy at follow-up, as opposed to 14 at baseline. The effect size was large, and there were no difference between post-treatment and follow-up scores. In this study, both group and individual PFMT were comparable to treat UI in older women for most of the outcomes. Both resulted in pelvic floor morphometrical changes on cough and functional improvements on several tasks that were sustained at 1 year. Of note, the more effective pelvic floor muscle contraction on effort may suggest that this continence strategy was well integrated by our study population. Finally, our participants included older women with UI who were available, willing to participate, and had few comorbidities. Therefore, these results may not be generalized to other populations, such as younger or frail elderly women. In conclusion, in women aged 60 and over with stress or mixed UI, individual and group-based physiotherapy resulted in comparable improvements in pelvic floor morphometry and pelvic floor muscle function that were sustained at 1 year. These results suggest improved support and control of the pelvic floor muscles, which was reinforced by the participants' reported self-efficacy in performing exercises. We are happy to say that the full report of these results are now available in NAU, and we would like to acknowledge our founders, the ICS Scientific Committee, and I thank you for your attention.